Hello, everybody. My name is Dr. Jacob Sexton. I'm one of the non-operative primary care sports medicine physicians here at the Andrews Institute Children's Health. And today we're going to be talking about the athlete and the environment. So first off, I have no financial disclosures for this activity. The objectives for this lecture, since it's early in the year and football season started, I thought this would be a great opportunity to review the purpose and functions of emergency action plans as these tie into my athlete and environment questions, because then we're going to follow up by discussing the physiology and management of heat and cold related illness. And then we're going to briefly talk about the physiological adaptations of altitude and the management of altitude related illnesses in athletes. So probably one of the most important parts of sports medicine and athletic event coverage is the emergency action plan. So what exactly is an emergency action plan? It's a standardized set of guidelines and templates to assist in the preparation of catastrophic injuries at large gathering events. The emergency action plan contains details for specific roles and the chain of command within the athletic healthcare team. When you have an emergency action plan, they should always be venue specific. They should always be sport specific, and they should be environmental specific as well as emergency specific. So why do we need emergency action plans? Multiple professional organizations across the United States have all agreed that there needs to be some sort of standardized protocol set up for any sports related to large gathering venue events to help reduce the chance of catastrophic event and have an appropriate chain of command whenever catastrophic events or other emergencies do arise during sports participation coverage. So probably the most important part of the emergency action plan is the chain of command. It's important when creating your emergency action plan that you have a set guideline of who's going to be at the top of your emergency action plans, who's going to be responsible for activating the emergency action plans during athletic events, what resources are available. Is it going to be basic emergency medical technicians? Are you going to have full paramedics available at the venue site? Or are you in a rural location where you won't have EMS services available? So therefore you have to contact whenever an emergency arises in order to have EMS arrive at your venue. Then you also need to understand, where do the external transports go? Is it going to go to the local trauma center? Is it going to go to local community critical access hospital? Or is it going to go to some sort of urgent care? Then we also need to understand venue access. Are there any special gates that are locked that would prevent EMS systems from arriving to your venue? Is there any issues getting to the venue itself, such as some events have fishbowl type courts and stadiums where you have to actually descend into a level and actually get onto the venue site? And then you should always have all the emergency medical service and venue contact specific numbers. And then, of course, during the competition, you should understand the chain of command is who's monitoring the venue and who's also monitoring the local weather events during that time. And then post-competition in the chain of command, whoever's the head healthcare provider at the venue at that time needs to have a post-competition huddle to review any emergency action plan activation, any positives and any negatives that occurred during that activation time, as well as communicating with the events. That includes the people who created the venue, that includes the EMS personnel, as well as the coaches, the athletes, as well as communicating with any guardians that might be need to be contacted. So the emergency action plan, the venue. Whenever you're creating an EAP, you should always have a venue map that's easily detailed, that identifies all the key important items that you would need during an EAP activation. You should always have locations identified for your sudden cardiac arrest. So that's your AED location. You should always have identification where the athletic trainer or other members of the athletic healthcare team are going to be located, be it on the sideline or be it at a medical tent. You should also have the field and the venue where they're actually playing labeled, as well as any obstructions that would prevent appropriate or timely access to the venue. And then as well as the EMS route that's anticipated to take. Because sometimes some of these local or more rural events, particularly cross country, marathon events, and those type things, some of these back access roads might not be readily identifiable or readily accessible. So they need to be easily labeled so that in the event the EAP is activated, that all members of the athletic healthcare team can help guide EMS to the appropriate location. So what should you evaluate for and what should you prepare for in your emergency action plan? Of course, you should cover any kind of sudden cardiac arrest emergency action plan. This identifies what is the activation for the EAP. This identifies how do you get access to the AED, Where is the AED located? Where are the other medical bags? Do you have any ACLS medications if you have advanced level providers there, such as physicians? The other things to consider is exertional heat illness, which we'll be discussing a little bit later. You should have the protocol for your cold water immersion. You should have your protocol for contacting EMS. You should have your protocol for transport, and as well as continuous management of those athletes. You should also have environmental exposures covered. This includes lightning, flooding, and all those other things that may occur at your athletic venue. This should incorporate weather monitoring systems. This should incorporate safe refuge in the event of catastrophic weather for both the athletes and the spectators if possible. It should also have a safe return to play criteria in the event that the catastrophic weather or other situations pass over. Your AP should also take into account sport-specific injuries as well as spinal-related injuries. So anytime that you're dealing with sports that involves multiple equipment, such as football, there needs to be a protocol standardized for who is going to be first to stabilize C-spine, who's going to be responsible for equipment removal, and is the local protocol going to be to remove the equipment on the field where the athletic care team is more comfortable, or is the equipment removal going to occur at the emergency department, where typically they are not as commonly trained in athletic healthcare emergencies. And so those are conversations that need to be had when establishing these EAPs. And then finally, concussion and head related injuries. Who's going to be the person that takes the athlete off the field? Who is the person that ultimately makes the decision for continued play or restriction from play? Who is going to ultimately manage the follow-up care for these concussion-related or head-related injuries, as well as need for any further transport in the event of altered mental status or focal neurological findings. And then finally, your emergency action plan should always have a maintenance phase, and it should be continuous throughout the year. In the preseason time, during this time right now when football is getting started up, this is the best time to have an on-site simulation. The first time you go through your EAP should not be during an actual emergency. You should already have this practice with your local athletic healthcare team, hopefully your local emergency medicine services, and if you can possibly get a hold of them, the emergency department and other EMS related individuals, to make sure that when the EAP does get activated, it occurs in a timely and professional manner without any hitches. And then the other things to consider in the preseason would be the equipment needs. So if it's a football related venue you'll be covering, of course, you're going to need face mask removal equipment, as well as considering other events such as swimming and diving sports. How will we have your access to the pool, and who will be assisting in those kind of emergencies? During the intra-season, it's important before every game that you have a pre-game meet and greet, as you can see on these two photos here. It gives you an opportunity to introduce yourself as part of the athletic healthcare team to the physicians, to the coaches, and to the opposing team to let them know that you're there and available. It gives you an opportunity to go through emergency signals such as, hey, this is when I want you to come on the field, or this is when I'm going to be activating my EAP. It also gives you an opportunity to talk with EMS about the most appropriate transport and where their current protocols allow them to transport their athletes. And then in the postseason, it's always important that you have an annual review of the current EAP and any previous activations that occurred during that year to see if there's any positives that occurred throughout the year and what can stay on the EAP, as well as identifying any negatives or any deficiencies that can be improved upon. So for the next season comes, the EAP would be more efficient at that point in time. Now that we've discussed emergency action plans, now we're going to discuss the athlete and the environment, initially starting with exertional heat illness and cold-related exposures. First, we need to discuss how is temperature regulated within athletes and within the environment. Core body temperature is regulated by two mechanisms. Centrally by the hypothalamus, which regulates about 90% of our internal core body temperature, as well as peripherally with our skin thermoreceptors responsible for the other 10% of internal core regulation. Elevated internal core temperatures, also known as hyperthermia, induces peripheral vasodilation, which allows heat dissipation to the skin, to the ambient environment. It also allows sweat production. And by sweat production, it takes that internal heat that occurs during exercise, and as it gets transported to the surface in the form of sweat, it is subsequently dissipated off into the environment through wind and other exposures and evaporation. It also induces splanchnic or intestinal vasoconstriction. So instead of having blood pulling into the main core body, the body is going to attempt to move the blood and the volume to the extremities to help dissipate that heat and help protect the internal organs. But with prolonged core body temperatures, typically exceeding 105 degrees Fahrenheit, That results in protein denaturation. So the proteins and chemical pathways no longer function properly. You then have central nervous system dysfunction, and that's when we classically see the signs of exertional heat stroke, such as altered mental status and focal neurological findings. And then ultimately, with prolonged heat exposure and hyperthermia, you result in end organ failure. So that's when you start seeing acute kidney failure. This is when you see rhabdomyolysis, extreme dehydration, and subsequent cardiac arrest and cardiac death. Now, what about cold-related exposures? Kind of the exact opposite. So hypothermia reduces peripheral vasoconstriction. So you're going to try to clamp down those peripheral blood vessels and try to get that blood pulling into the central core body in order to maintain that internal core temperature. You're going to have increased central venous pressure, and that occurs from those constriction of those blood vessels. It makes all the blood pull into that central core area, and that ultimately causes more blood to return back to the heart. You also have increased skeletal muscle tone in order to prepare for shivering and other modes of heat production during exercise. And then you also have increased ventilation at that point in time in order to increase your core body temperature. Prolonged core body temperatures below 95 degrees meets the definition of hypothermia. And when that occurs, you have a loss of your typical heat production mechanism. So the first that's typically noticed is loss of the shivering mechanism. So then followed by central nervous system dysfunction. So that's your altered mental status, that's your confusion. Sometimes you'll have focal neurological findings, but that's more commonly seen in exertional heat related issues. You then ultimately will result in end organ failure from lack of perfusion, as well as blood clots and other issues that occur with cold body temperatures. And then ultimately you will have underlying arrhythmias and sudden cardiac arrest with prolonged hypothermia. So exactly how do we go about as humans with thermoregulation during exercise? The most important method of heat dissipation or heat removal in the body is evaporation. We briefly discussed this earlier. Whenever you actively perform exercise, heat is produced in the body and then gets transported to the superficial skin in the form of sweat. When sweat contacts the cooler ambient temperatures in the environment, such as wind or a lower total temperature index, that sweat will be evaporated and pulled off into the environment, thereby lowering the total core body temperature. Radiation, on the other hand, is electromagnetic energy transfer between two objects. Typically, people classically describe it as sunlight radiation, but it occurs from radiation just between two sources. This is the predominant method of heat loss during exercise. Most commonly occurs in high vascular areas, so the scalp, the axilla, the groin, and those type things. But typically with athletes, we're most concerned about the head, as typically the other areas are covered during athletic activity. So then we have convection. Convection is the transfer of heat to ambient environmental sources. So this is whenever you're running outside and you get that nice cool breeze going across your skin, that it makes you feel cool when you're exercising. That's the form of convection. And then conduction is a transfer of heat between two objects that are in direct contact with each other. This is most classically described as the benefits of cold water immersion. So you have a very hot structure, such as the person with exertional heat stroke, put into a cold water immersion bath as a much colder temperature, and that direct contact of the cold water to the skin will allow the transfer or conduction of heat from the hot skin into the cool ambient environment of the cold water immersion. And then finally, we need to consider the metabolic process of thermoregulation. Every time a muscle contracts, every time that there's a powerful force that occurs, you do have energy production in the form of ATP to allow contraction, but we must also understand that a portion of that energy is lost in the form of heat. And so we need to be aware of that during exercise as well. So heat-related deaths in athletes, this is from 2012. In American football, only about 0.16 deaths per 100,000 participants. Exertional heat-related illness is actually more common in long-distance activities such as marathons, where the rate is actually 1 in 1,000, which if you have the Boston Marathon, when you're having 30, 40, 50,000 people, you can see that your incidence is going to be pretty high at those events. Common risk factors for heat-related deaths in athletes, typically the preseason practice, so the period of time that we're in now, particularly during the acclimatization phase, the first week of conditioning, high wet bulb globe temperature readings, and then, of course, the months through July to September when the temperature is the hottest. So what are some risk factors for exertional heat illness? You have to think of this both internally and externally. So internally, anybody with a prior history of exertional heat illness is going to be predisposed to subsequent events of exertional heat related illness. And we believe this is a dysfunction in the central thermoregulation center in the hypothalamus. Obese individuals are going to be predisposed to exertional heat related illness. That's because they have more body surface area that occurs. Fat cells act as an insulator and will allow increased heat trapping during exercise. Other risk factors include sickle cell trait and sickle cell disease, as those individuals, when they reach a hypovolemic or dehydrated state, will subsequently have sickling of their red blood cells, which then result in end organ damage. Certain medications can also be implicated in exertional heat related illnesses. These are your anticholinergics, so high doses of Benadryl. This is your diuretics, which will predispose to hypovolemia and dehydration, as well as stimulants, amphetamines, such as your ADD medications, can also help predispose you to exertional heat related illness. We already briefly discussed dehydration, which kind of makes sense. The lower the total body volume in the body, the easier it is for temperature changes to occur, and subsequently easier for internal core body temperature elevations. And then, of course, diet. Externally, we need to think about the environment itself. Of course, that's your ambient temperature, that's your heat index, that's the wind speed, that's your humidity, all those things, and together all contribute to exertional heat related illness. We also should keep in consideration of the clothing and equipment for that period of activity. We should also consider the acclimatization of the athlete. So those individuals who are weekend warriors who've been sitting on the couch all summer and then decide that they want to play football August 1st and haven't done anything over the summer are going to be kind of predisposed to heat related illness. Timing is also important. It's not best during this time of year to be practicing from noon to 5. You want to pick times that are best when the humidity is lower and the overall ambient temperature is lower. So in the morning and the evenings are the best time. And then having appropriate breaks and rest during athletic activity to allow for hydration and allow cooling of the athlete. So probably the most important part of exertional heat illness is prevention. And one of the best methods of prevention is appropriate acclimatization of the athletes. This is the process of becoming accustomed to a new climate or to new conditions. Typically, this takes about 10 to 14 days for most athletes in order to be adapted to the new ambient environment for which they are placed. Typically, by having them exposed to prolonged temperatures in this environment, it helps them physiologically adapt by preventing increases in their internal core body temperature. It helps reduce their underlying heart rate. It helps reduce and it helps promote heat dissipation and improve sweat production. Now, the other things that we need to consider about acclimatization is transition periods. So anytime an athlete has a prolonged period where they are out, so if they were out for like a month for an ankle sprain, they need to have a period of acclimatization when they return back to their athletic venue, particularly if they have not been doing any kind of external or outside activities while they were injured. The other times that we need to consider transition periods is return from school breaks. So if they have a few months off and they decided, like we talked about earlier, they did the weekend warrior approach and did nothing over the summer and decided to come back full throttle August 1st, then they need to have that period of acclimatization. And then you also need to consider any new athletes need to have this transition period as well. This is most commonly seen from athletes who go from the high school to the collegiate setting. Whenever they're going to be exposed to new workouts, they're going to be exposed to new training loads, new practice loads, and those type things. And that's when they're really going to be predisposed to having exertional heat related issues. And then it should be sport specific as well. There should be a gradual increase in the load and activity. This is most commonly seen in football, as you can see in the bottom right image, where they start in kind of shells, where they might be wearing their helmet only for the first few days. After those first few days, then they transition to helmet plus shoulder pads. And then after about a week, then they'll transition to full pads where they'll have full contact and then be practicing at their sport specific activities. So prevention for hydration, probably the most important part. 1% body mass loss during exercise increases the internal core temperature by approximately 0.5 degrees Fahrenheit. So you can imagine somebody who loses just 2 to 3% of their total body weight during exercise in a short period of time, their internal core body temperature is already going to be up a few degrees before they even get into the danger zones for exertional heat related issues. The next question is always asked, which is better during exercise, water or carbohydrate containing solutions? And the correct answer is both of them can work very well. Carbohydrates are a little bit better in regards to hydration, as the glucose in the carbohydrate containing solution enhances sodium absorption and water retention through osmosis in the small intestines. Now, there's a limit to that. And most over-the-counter and store-bought carbohydrate-containing solutions contain about 7 to 8% of carbohydrate. And the reason for that is when the carbohydrate solution gets above 10% or so, you actually have the opposite effect, and you will promote an osmotic diuresis or osmotic diarrhea, where you're going to have increased volume losses through the intestines as the glucose and other carbohydrates will actually pull the free water through the intestines. So that's why it's important that when you're mixing your Gatorade solutions, your Powerade solutions, whatever electrolyte solution that you're using, that you're not overly concentrated in it, that you're diluting it appropriately. And then, of course, during athletic activity, you want to avoid any caffeinated containing items such as sodas, coffee, alcohol, etc., that have any diuretic effect, as any diuretic effect is going to lead you to hypovolemia, subsequent dehydration, and subsequent increased risk of exertional heat illness. So now hydration. So the American College of Sports Medicine did come out with guidelines back in 2008, I believe. This is the AMSSM recommendation during pre-workout. They recommend approximately 20 ounces of water or carbohydrate containing solutions, approximately 1 hour prior to exercise. During workouts, about 10 ounces every 15 minutes based on the thirst level. And then post-workout, approximately 20 ounces of water or carbohydrate containing solution per pound of weight loss. The other thing you consider during hydration and during athletic events is total volume loss post-exercise should not exceed 2% of pre-exercise body weight, which kind of brings up the importance of a weight monitoring program with our athletes. I know it's kind of a pain, particularly during the early summer weeks whenever we're in our preconditioning and starting our contacts for football related issues, but a weight monitoring program can really help you find those athletes and identify those athletes who are not appropriately hydrating, who are subsequently setting themselves up for subsequent exertional heat related illness the following days. And then how much water should you replace after activity? So they have a pretty simple formula, but for me, it's pretty easy. For every 1 pound of weight you lost, you drink a half a liter of water to replace that. And then I have them converted to ounces for us American folks as well. So what else can we do for prevention? The environment's the other thing we need to consider about with exertional heat related illness. Timing, we need to avoid periods of prolonged direct sunlight or peak temperatures. That's kind of a given. The other things that we need to consider are the activity modifications and restrictions. Those are kind of changed depending on what state and what region you're in. They can be local guidelines, state or federal. You can utilize ambient heat temperatures such as the heat index or wet bulb globe temperatures. And this should definitely be a component of your emergency action plan. So that way, if anyone's giving you pushback, you can say, hey, this isn't our EAP. This is why we cancel sports related activities at this time or with these associated environmental temperatures. The wet bulb globe temperature is an accurate method to measure extrinsic sources of heat. It takes into account not only just the temperature, but the relative humidity, the wind speed, and radiation at the athletic venue. So the top right image shows one of the classic wet bulb globe thermometers, although nowadays you can pretty much pull up your phone, pull up an app, and they will have a wet bulb globe thermometer index reading for you on most of these apps. Now, the bottom right image is from the weather services that's just come out. It's currently in its beta phase. But with this one, you can go to their website, you literally click on the city, town, venue, or you could even put in the latitude and longitude, and it will give you the current wet bulb globe thermometer index, as well as the relative heat index for that local area at that given time. So it's a pretty real-time interactive monitoring system that I think is going to be pretty useful in the future. This is a method. This is the Frisco Independent School District, which is one of the school districts I work at. This is their heat-related illness protocol. So on the left image, you have the National Weather Service heat index card, which is their reference phase. And then on the right, you have their standardized heat index considerations and athletic activity cessation guidelines. And as you can see there, as of course the temperature gets hotter, there's more breaks required, less time spent on the field, and more time spent with breaks. Ultimately, with anything above 110 degrees of actual temp or heat index greater than 115, there's complete cessation and postponement of all athletic activities. This slide here comes from the Georgia High School Athletic Association. This is kind of their guidelines for using the wet bulb globe temperature index. As you can see, under 82, normal activities, no restrictions. And as that wet bulb globe index increases, Then you have subsequent changes into how long you're allowed to practice, when you can practice, and where you can practice, with subsequent discontinuation of activity with any wet bulb globe temperature greater than 92.1. So management of exertional heat related illness. Whenever I'm dealing with these things, I try to separate things pretty simple, make it straightforward, because emergencies do best whenever there is a set protocol and set guidelines you can follow, so you're not having to think too much during emergencies. So the most important thing, of course, is recognition, followed by evaluation, followed by cold water immersion and cooling, and then finally followed by transport to advanced level of care and advanced emergency services. So exertional heat illness is a spectrum of illness ranging from heat exhaustion to frank heat stroke. Early identification of exertional heat exhaustion can prevent subsequent exertional heat stroke. The things to consider, though, when treating heat-related illness is consider the alternative diagnosis that occurred during that time. So one of the ones I consider is during long marathon events. If I have a patient who has altered mental status, has an internal core temperature that's not elevated, I need to consider of hyponatremia. Same thing if I have a young individual who has cramping type events, who's got soft, easily compressible cramp, soft, easily compressible calves, but still has evidence of cramping, then I need to think of sickle cell crisis. Same thing with hypoglycemia, rhabdomyolysis, as well as underlying cardiac arrhythmias. The definition of exertional heat stroke occurs when there's hyperthermia greater than 104.9 degrees Fahrenheit rectally. And that's one of the most important parts. It has to be rectal, axillary, temporal, oral. No other methods of temperature readings is accepted except for rectal in regards to exertional heat illness. There needs to also be evidence of end-organ dysfunction, particularly the central nervous system. And typically when diagnosing exertional heat stroke, that is going to be the organ system that is going to help identify for you, as typically it is the easiest to assess. As other internal organs such as the kidneys, the heart, and those type things, it's more subjective measures. Diaphoresis lacks the sensitivity for diagnosis of heat stroke, as it can be both present and or absent in the setting of exertional heat stroke, even while internal core body temperature is greater than 104.9. And if anything, I want to emphasize on this is just because an athlete is sweating does not mean they are not in exertional heat stroke. And so I just want to emphasize that point here on this slide. So why do we use rectal core temperatures? So these are two charts that were obtained back in the marathons back in 2020, and I believe the other one on the left was 2018. So basically what they did is they had a mass event of marathon athletes, and whenever they crossed the finish line and they came to the medical tent for evaluations for suspected heat exhaustion or suspected heat stroke, they had both a rectal temperature performed and a temporal arterial temperature performed on the left image. And then on the right image, they had a rectal temperature performed and an infrared tympanic thermometer reading on the right. As you can see with both, there's a significant difference between the two, approximately 2 degrees Celsius difference noted between both of these studies, which just help emphasize and help solidify the importance of a rectal temperature when suspecting and dealing with exertional heat related illness. So then we talk about cooling with exertional heat illness. The number one indicator of death for those with exertional heat stroke and exertional heat illness is total time of elevated core internal body temperature. The goal for temperature decrease with cooling these athletes is 0.15 degrees Celsius in core body temperature per minute. And the definitive treatment for this is cold water immersion. Cold water immersion is preferable, as given the oscillation and direct conduction to the athlete, it actually meets that goal temperature decrease criteria as opposed to other methods. And then the other consideration you can do is TARP assisted cooling with oscillation, which I'm going to show an example in a second. The image on the right is a study that showed these varying methods of cooling individuals, all the way down from ice packs on the left, all the way down to ice water immersion on the right. And as you can see, from tap water splashing in the middle, about right here, from tap water splashing to cold water immersion, you do not meet that goal temperature decrease till you get to that cold water immersion level. Anything to the left of this is just not efficient enough, and it's not going to cool the athlete well enough. And my favorite one on here is the helicopter downdraft, which unfortunately is not an effective method of cooling athletes. So this is an image of typical cold water immersion bath. It can be any kind of hard plastic tub or chute, and it should be available at all of your athletic venues and should be a component of your EAP. So you just fill it up with ice, have the ice available. You subsequently fill it up with water, and you just dunk the athlete in there. Now, the things that you need to do beforehand, make sure they have the rectal probe or rectal thermometer appropriately placed. So when they're placed in there, and the other thing is, since the athlete's going to have altered mental status and confusion during that time, you need to be prepared to help assist them, prevent them from falling down into the tub. So you can use a towel or a blanket to kind of put it underneath their axilla and hold them up in the tub. And sometimes with the altered mental status, they'll be combative. And so having support staff there to help you prevent them from harming themselves and harming anyone else while they're appropriately being cooled. This image is the taco method. So the taco method is basically you take a large tarp, you place the athlete into the tarp, you subsequently roll the tarp up into the taco, you put water and ice in the taco, and then you and your colleagues subsequently oscillate or move the water back and forth to take advantage of the conduction that occurs same way with cold water immersion. Now, out of the two, cold water immersion total contact baths are better, as the more surface area that's in direct contact with the cold water is going to help improve and help dissipate that heat. While with the taco method, you're not going to really be able to put a lot of ice, a lot of water in there, as weight and other matters start interfering with your ability to oscillate properly. Now we're going to talk about cooling with exertional heat illness, as we already talked about cold water immersion. If you pick nothing else up for my heat-related exposure part of this lecture, please pick this up. The most important part is to cool the athlete first and transport second. And as we discussed earlier, the number one indicator for death is how long the internal core body temperature is greater than 104.9. And from what we can see here, the internal core temperature goal with cold water immersion is a temperature less than 101.5 degrees Fahrenheit. Now, when you have the person in the cold water immersion, you do want to continually monitor them for iatrogenic hypothermia, which is okay. That we can normalize their core body temperature once they get transported, but the most important part is to get their core body temperature below that 101.5 mark. And as I mentioned earlier, transportation should always be delayed until the internal core temperature goal has been achieved, unless you have no other method of cooling the athlete at the venue site. The image on the right is an interesting study that I like to reference back for why is it so important to have this internal core temperature down. This is a study of rats. And as you can see here, they had the passive heat stroke versus induced exertional heat stroke. And as you can see, the survival curve dropped significantly off at that 30-minute mark. And the green bar that's represented there is the actual human response when they tested the, when they went back and compiled their data from heat stroke related athletes and individuals in the studies. They found that those who had an internal core temperature below 101.5 within 30 minutes after the onset of exertional heat stroke and cold water immersion, they had a 100% survival rate. And that is the biggest thing to take off this slide, is if you can get them in the core temperature below 101.5 within 30 minutes, their survival rate and functional outcomes are amazing. And as you can see, from that 30 minutes to 60-minute mark, you have a significant drop off from 100% down to about 40% in the rat population. So this is my guideline chart that I put on with any time I deal with triage. So you have a patient who collapses during or after physical activity with a known heat exposure. The first thing you should see is, are they responsive to command? Because if they're not responsive to command at all, you need to activate your EAP, start activation your basic life support or advanced cardiac life support services at that point in time. If they are responsive to commands, is there any evidence of altered mental status? If there's none, then remove them from the activity and continuous monitoring at that point in time. If there is evidence of altered mental status, then you need to assess the core temperature, and it needs to be rectally. If the temperature is less than 105 or 40.5 degrees Celsius, supportive care at that point in time. If they have altered mental status, though, I'm still going to have a low threshold for cold water immersion and go ahead and transport them at that time. Now, if they do have a temperature greater than 105 and there's evidence of altered mental status, initiate the cold water immersion, put the rectal thermometer in, stick them in the cold water, get them below that 101.5 mark, and then transport them to advanced medical care. So then we're going to transition to cold-related illness and cold-related exposure. So as opposed to heat-related illness, the literature is not as robust in regards to cold-related exposure, cold-related deaths, as most cold-related deaths in athletes are accidental exposures in nature. But as you can see here from the United States CDC, there's approximately 0.2 to 1 deaths in the general population per 100,000 to cold-related exposures every year. The environmental and seasonal patterns limit cold exposure, as very few sports are deeply ingrained into the winter activities. And you have lower risk of sudden death as compared to heat-related exposures, as hypothermia does have some neuro and cardioprotective properties as compared to heat-related issues. So same thing with exertional heat-related illness. You both have your internal risk factors and your external risk factors for cold-related illness. So internally, lean athletes are going to be more predisposed for cold-related issues. Kind of pretty straightforward: less adipose tissue, less fat tissue, less insulation, easier to lose heat. Hypoglycemia is another issue that can predispose these individuals to cold-related issues. If an individual has not been eating, has not had the appropriate nutrition prior to exercise, and then they're subsequently placed into a cold environment, they're not going to have the glucose and glycogen stores necessary to have the energy production to promote shivering. And so those individuals are going to fatigue faster and subsequently go into lose their heat production sources faster than those who are appropriately eating. Same thing with fatigue and sleep deprivation. And then internally, cold-related illness, reactive airway disease can kind of predispose you to bronchospasm, those other type things during exercise. Externally, exercising in wet environments, of course, is going to predispose you to cold-related illness. So it's important to limit the amount of time that an athlete is wet when externally exercising. Clothing and equipment, probably more so important than heat-related illness. It's got to be appropriately layered. It's got to be appropriately insulated for whatever specific venue that the athlete is participating in. They should also have a period of acclimatization, similar to heat-related exposures, in order to make sure that the body can physiologically adapt to those environmental stressors. Another risk factor for cold-related issue is actually completion of exercise. So after exercise is completed, you lose the sympathetic drive. You have your internal core body temperature raised. Your body's going to start dissipating that heat that's already being produced. And since your internal core temperature is already elevated, your typical heat production methods such as shivering and those type things are not going to be activated. And those will not activate till you already completed the exercise and your core body temperature is already starting to go down into the hypothermic range. And then the body has to play catch up at that point in time. And of course, altitude greater than 8,000 feet is going to predispose you to cold-related issues because it's high elevation. So how do we prevent cold-related illness and how do we produce our heat? So we do it by two different methods. First is, of course, to increase your own heat production. But unfortunately, increasing heat production is the least effective way to prevent cold-related illness. And this is your shivering and this is your exercise. Other way to increase heat production, as we discussed earlier, is adequate nutrition in order to have appropriate glycogen stores and fat storage. So you have plenty of excess energy reserves to promote shivering and promote heat production during activity. And then, of course, hydration is always important to help prevent underlying hypovolemia and circulatory impairment. The most effective way, though, is to prevent heat loss. And that involves layering of your clothing, maintaining adequate trunk warmth, preventing radiant heat loss from the head, as well as using other special protective equipment, such as goggles to protect the eyes from UV exposure, mittens or gloves, as well as face shields or whatever you need to help prevent those extremities and digits, such as the nose, cartilage structures, fingers, toes, from getting unnecessary exposures. Next, we're going to be talking about layering and prevention. The two key important parts when considering layering and clothing for athletes in cold exposures is insulation and permeability. Most cold weather systems are composed of 3 layers, and these can be taken on and off as needed, depending on what the competition is, what their current exercise training level is, and what the ambient environment is. But typically your inner layer wants to be a hydrophobic polyester fabric. So that's your classic Under Armour in the top left image. It allows for wicking of the sweat off directly from the skin and help prevents it from dissipating into the environment. While your middle layer is more of your insulating material. So that's your middle right image. So this is the one that's typically going to have some kind of insulated material. It can be a synthetic, it can be down, it can be any kind of material. The goal with this is to help produce that heat and help hold it and keep it trapped in between the inner layer. And then finally, you have your outer layer. That's your windproof and your water repellent shield. So that's your rain jackets, your starter jackets, and those type things to help protect you from the actual environmental exposure. When you're layering, it's important to avoid excessive wetting. Obviously, if you're Athletes' layered clothes get sweat. It's important to remove them and replace them if possible, as the longer that they're predisposed and longer they're placed in wet clothes, the increased chance for hypothermia to develop. You want to avoid tight-fitting clothing, and the reason you want to avoid tight-fitting clothing is between that inner and that middle layer, you want a little bit of air trapping to occur, and that'll help trap that warm air and help keep that internal core temperature from occurring. If the air is too tight, it will prevent any excess air from getting in, and will actually help promote heat loss, as there's no way for that air to be trapped and it'll be lost into the environment. And then, of course, you want to avoid any tight-fitting garments around the fingers and toes. So next, we're going to talk about the environment and its response in the cold-related illness. Most cold-related illnesses in athletes is related to prolonged incidental exposure. The ambient temperature and surrounding winds causes a relative equivalent temperature as compared to the environment, also known as the wind chill. All components of heat dissipation are involved with heat loss during cold environments. This includes radiation from the head, so this is why it's important to have appropriate head coverings during athletic activity. Conduction is important when you have direct contact with water, so this is the pool, and this is your layered clothes that occur, which helps promote heat dissipation. But most importantly, and probably most importantly, is convection. As the air temperature drops and there's a greater discrepancy between the internal core temperature and the ambient external temperature, that heat dissipation from wind exposure and that conduction is going to be 4 times the baseline from normal. So that's really where you're going to start losing your heat, particularly if you do have sweating and evaporation and occur in conjunction with that. This is the Frisco Independent School District cold-related illness protocol. They use the calculated wind chill temperature index. It's got a nice formula there that you can fill out in as you need to. But most importantly, what you see from the cold-related exposure is not only does it take the ambient temperature, but it also takes in the environmental temperature. So it's rain and wind chill. And as you can see here, they have 2 separate guidelines for both their high schools and their middle schools. But in particular, what you see is anytime it gets close to the freezing range, particularly anywhere it gets close to freezing, or if there's any rain or wind chill, your threshold for outside activity decreases, and you're not really exposed for that long period of time. So again, cold-related illness management, it's important for the recognition phase of it. Then you need to evaluate again. As opposed to cooling, we're going to be warming, focusing on warming this time, and then transport to advanced level of care. Cold-related illness is, again, a spectrum of illnesses. What we need, the first thing is hypothermia is your systemic core body temperature, less than 95 degrees Fahrenheit. We also need to think about the soft tissue injuries that occur with cold-related exposure, such as frostbite and chilblains. We need to think about the respiratory aspect. With the dry, cold air, you can have cold-induced bronchospasm. So that's when you can get your cold-induced bronchospasm and exercise-induced asthma. And then you need to think about the ocular aspect of it. So the images on the right is photokeratitis or snow blindness. These are individuals that are typically up in snow skiing or in a very snowy environment where the reflection from the sun can actually interfere and actually cause burning of the eyes and actually cause disruption of the eyes, which you can see here on this fluorescein scan on the bottom right image. And then hypothermia is graded kind of mild between 90 to 95 degrees Fahrenheit, moderate 82 to 90 degrees Fahrenheit, and then anything severe less than 82 degrees Fahrenheit. So hypothermia presents, you always need to assume hypothermia in a cold exposed athlete. When any evidence of confusion, dysarthria, so difficulty speaking, slurred words, mumbled speech, and or ataxia. So any evidence of gait disturbances. Do they have a wide-based gait? Are they stumbling? Basically, if you think they're drunk, then they're probably got hypothermia at that point in time. So with mild hypothermia, typically that's more of the confusion, the dysarthria. You get some cold exposure diuresis as well as apathy. At moderate hypothermia, that's when you start getting the real lethargy, you start getting stupor, you start getting loss of your shivering and your heat production mechanisms. Arrhythmias and hypotension can start developing at that point in time. Once you get to the severe aspect of hypothermia, that's when you're going to be dealing with coma, hypotension, muscle rigidity, so basically rigor mortis at that point in time, arrhythmias, pulmonary edema, and then you get your coagulopathies. So the bottom right image is the one I always like to use. This is an EKG reading of somebody who has hypothermia. The first thing you notice is they're going to be bradycardic, so their heart rate is very slow at this point in time, which is one of the effects of cold exposure. The next thing that you see is their QRS complex, so their ventricular contraction is widened. So there's actually a delay that's occurring with their ventricular contraction. And this is why these athletes and these individuals with severe hypothermia are predisposed to ventricular arrhythmias, such as ventricular tachycardia and ventricular fibrillation. But most importantly, it gets this cool little hump here that you can see on the EKG, and that's called an Osborne wave. And that's very specific for hypothermia. And if you identify that on an EKG, then typically you can assume this is a cold exposure incident until proven otherwise. So cold-related illness evaluation, I just want to put a big slide about thermometers. Like heat-related illness, internal core temperature establishes the definitive diagnosis. The big thing that we need to understand is most of our thermometers are set for high temperatures. They're not really set for cold temperatures. So if you're going to be covering an athletic venue that has a chance for hypothermia or other cold-related exposures, you need to make sure that your thermometer is calibrated for low temperatures as well as high temperatures. So cold-related illness and management, the goal is to prevent further heat loss, okay? First thing is to remove the individual from cold to an insulated shelter. So you can see my top right image, you actually have a snowbank shelter that was created there, and that's part of wilderness medicine at that point in time. You want to remove all the wet clothing to limit conduction from occurring, as well as convection heat loss. You want the patient position to be horizontal. So you'd rather have them laying down, laying flat instead of being upright, because these individuals are going to already have cold-induced diuresis. They're already going to be hypovolemic. They're already going to be energy starved from the shivering that's occurred. So you want to prevent any kind of syncope or any further injuries from occurring. So that's why you lay them flat during the evaluation. And then if there's evidence of hypothermia and frostbite present in an athlete, you should always treat the hypothermia first, as you want to remove the risk for any arrhythmias, any end organ damage from occurring. And then you can start managing the extremities with the frostbite. So for mild hypothermia, as we discussed earlier, that's between 90 and 95 degrees Fahrenheit. The best method to do is just kind of passive rewarming. So you provide warm food and non-caffeinated beverages at that point in time. You avoid the caffeinated beverages, as you don't want to promote any more diuresis to occur. You also want passive rewarming, allow the patient to kind of shiver back to normal, as opposed to when you get to moderate severe, where you're doing active internal rewarming measures. By doing active internal rewarming measures, you can actually blunt the passive rewarming and physiological shivering back to normal. Typically, though, those with mild hypothermia have intact warming mechanism and require only supportive care. Now, for your moderate and severe hypothermia, so this is between 82 and 90 degrees, or anything lower than 82 degrees, the goal is definitely to prevent further heat loss at that time. Basic life support measures, your emergency action plan, and all those other things should be activated at that point in time. At this point in time, you also want to consider active external rewarming prior to transport. So there are a few methods you can do with that. One is humidified warm oxygen. That'll increase their core body temperature by about 1 to 2 degrees Celsius per hour. Another consideration would be warmed intravenous solution, so D5 normal. And the reason you want the dextrose is to help improve and restore some of those glycogen and glucose stores that have been lost during the hypothermia exposure. You can also consider external warming, such as bear huggers, hot packs over high areas, so you're growing your axilla, body-to-body contact, and then finally warm water immersion. And then making sure your warm water is not too hot. 110 to 113 degrees is appropriate. But typically, if you get to the moderate severe phase where you have stupor, ataxia, focal neurological findings in that time, they're typically unable to rewarm themselves, and they do require advanced medical care and transport. So cold-related illness and cardiac arrest. I think this isn't something too important to discuss because it varies a little different from your traditional ACLS guidelines. So cardiopulmonary resuscitation should be initiated if no pulse or breathing is identified after 60 seconds. And now this is for hypothermia patients only. Initiating CPR in somebody with a pulse, as we discussed earlier, already has that widened QRS EKG, who's already predisposed to ventricular tachycardia and ventricular fibrillation. By putting an external force onto the chest and compression with a discernible pulse, you can actually induce that ventricular fibrillation and ventricular tachycardia, and then you're going to be dealing with a whole different host of issues. With core temperatures below 86 degrees Fahrenheit, all of your medications are not indicated because they no longer work. your epinephrine, your atropine, all those different medications, physiologically, they do not work at those cold temperatures. And the other thing that occurs is your typical metabolic pathways are no longer functioning properly either. So they don't hit the receptors and they don't activate like they typically do. So the only definitive management for if it's a shockable rhythm is defibrillation. Once your core temperature is greater than 86 degrees Fahrenheit, then you can start considering your ACLS medications, which is epinephrine, atropine, lidocaine, and whatever you have available at that point in time. In patients with known moderate to severe hypothermia requiring ACLS, a patient should not be pronounced dead until they are warm and dead, okay? Because hypothermia is actually cardioprotective and neuroprotective without prolonged exposures. And so if we can properly resuscitate these individuals to a normal core body temperature, sometimes we can have recovery and full cardio and neurological recovery without any further deficits. And then most importantly, as with everything else, CPR should not delay your transport. As opposed to heat-related illness, the goal of cold-related exposure, cold-related illness is get them into transport, start actively rewarming them and getting them to the further level of care to prevent any excessive end organ damage. So same thing as my exertional heat-related illness. This is kind of my treatment pathway for hypothermia and cold-related illness. The biggest one is once you remove them from the environment, you assess the mental status and you've established your ABCs. If there's no respiration or pulse, you're going to go down your EAP and your ACLS pathway. And then shocking only if the core temperature is less than 80 degrees, as we talked about earlier. And then you can use your ACLS medications once your internal core temperature is greater than 86 degrees. Well, if they do have a respiration and pulse, then you go down to the hypothermia. Is it present? Yes or no? There's no evidence of hypothermia. You just kind of let them actively rewarm, let them have supportive care, and just do a secondary survey at that time. But if there is hypothermia present, then you're going to go through passive rewarming and assess that core rectal temperature. If it's evidence of mild hypothermia, then again, like we talked about, you want to let them passively rewarm and shiver themselves back to normal. While on the other end, if there's any neurological finding, any evidence of a temperature below 90 degrees, they're getting to that moderate severe stage, then you want to consider that active internal rewarming. You want to consider active external rewarming. You want to get them removed from the environment, and then you're going to transport them to the higher level of care to make sure there's no evidence of end organ damage that has occurred. So quickly, just talk about frostbite. So frostbite is just localized cold tissue injury by freezing of soft tissues. It goes through a couple of phases. The first phase is the pre-freeze phase, where you have alternating constriction and dilation of these peripheral blood vessels. That subsequently results in tissue edema. So that's why you get those sausage type digits when you first start getting your fingers cold. You get that edema from a skate from there. If you have continued exposure at that point in time, then you go into the freeze thaw phase, where your body is going to actually form intracellular ice crystals, and then those will subsequently melt, and then they'll refreeze again. And that's what causes the initial tissue damage to occurs. At that point in time, you're going to have red digits, and that's when you might start developing some blistering at that point in time. After the freeze thaw phase, you get into the vascular stasis phase. So that's when you get the vasospasm, vasodilation, and then you have kind of permanent ice crystal formation. And then if you keep letting the exposure occur, then you get into the ischemic phase, where you actually have shunting of the circulatory supply around those ice crystal areas. That subsequently leads to tissue ischemia, which results in tissue necrosis and then vascular thrombi. And that's when you start getting the dead tissue, which can take weeks to months to finally kind of present itself if it's going to be salvageable or not. Clinically, they were classification. In the past, it was described as first, second, third, fourth degree, but now it's more been changed to superficial for your first and second degree, so evidence of blistering. And then you have your deep, your third and fourth, where you start getting to the dermis and subcutaneous tissue layers. So for frostbite general management, the treatment goal is for adequate thawing of the tissue while preventing refreezing. You should consider using anti-inflammatory medication such as ibuprofen, Motrin, Mobic, any of those, as they will inhibit the inflammatory mediators, and so therefore reduce the amount of swelling, amount of edema, amount of vascular damage, while also promoting an analgesic effect for the patient. Definitive treatment for frostbite is rapid rewarming of the soft tissue. So you can do this with warm water circulation at 104 to 108 degrees. You want to do active motion during the rewarming. And then for the most part, these blisters are sterile. So if they are not over a major joint line or not causing too many issues, you can leave them as they are. But if they do cross a major joint line or causing discomfort, you can de-roof them as they are sterile in nature. You want to avoid soft tissue massage, particularly during the freezing and during the thawing phase, as tissue massage can actually crush the underlying tissues that have ice within them, and that can result in permanent soft tissue damage. And then you also, for the same reason, you want to avoid dry or radiant heat, as that can promote soft tissue damage at that point in time. So typically the best method if you're dealing with a frostbite individual is to initiate your active internal rewarming measures and then placing the frostbite related areas into an exposed warm circulatory bath and allow them to promote themselves to kind of thaw themselves with active movements without massaging the affected area. So finally, we'll be discussing altitude in the athlete. So barometric pressure is reduced at high elevations with a parallel decrease in inspired partial pressure of oxygen. So athletes are going to be exposed to a relative hypobaric hypoxia. Temperature decreases approximately 11.7 degrees Fahrenheit for every 1,000 feet of elevation. You also have associated decreased humidity, so drier air. And then you have increased ultraviolet light exposure. You got an increase of 4% for every 300 meters that you go up. And as you see on the bottom right image, you kind of have your classification of what elevation is. So anything below 500 is near sea level. You get low altitude between 500 and 2,000 feet. And then you get into high altitude activities when you get above 3,000 feet of elevation. So what exactly happens to the athlete when they're exposed to altitude activities? Most commonly, we're going to be dealing with the acute exposure from the travel medicine standpoint and athletes. The first thing that occurs when you get in this hypobaric, hypoxic environment is your body's going to want to have its typical oxygen levels that it's accustomed to. So it responds to this by increasing pulmonary ventilation and minute ventilation. That subsequently is going to induce a respiratory alkalosis as you're going to breathe off more carbon dioxide that you're accustomed to. In response to that, the kidneys are going to counteract that and want to have and maintain homeostasis in the body. So it does that by actually promoting diuresis and excreting any excess bicarbonate that it can in order to promote a metabolic acidosis to maintain a natural body pH. The other thing that occurs is you have increased cardiac output, and that's typically seen with improved stroke volume and improved heart rate. And then the other thing that you're going to see is, from a hematologic standpoint, is an increased risk of sickle cell crisis, and which makes sense. You're in a hypoxic environment. You put somebody into an environment that their red blood cells will sickle in the presence of hypoxia, so they're going to be predisposed to those events. And there's also a question of, are you more hypercoagulable when you're training at these higher altitudes? Now, as opposed to acute exposures, with chronic exposures, you actually get kind of the opposite effects. So at that point in time, you get hypoventilation, as you're not going to need that respiratory alkalosis as you once needed. Instead, you're going to develop a pulmonary hypertension. So you're going to have a little bit higher blood response into the right side of the heart, which then subsequently results in right ventricular hypertrophy. But most importantly, from chronic exposures, and the reason athletes use training at altitudes, is you have an increased hemoglobin concentration, which subsequently improves total oxygen carrying capacity, which then will result in improved oxygen and aerobic performance. So these two charts just show the kind of acute exposure and chronic exposures on the right image from the different organ systems that occur. And the image on the left demonstrates the oxygen hemoglobin dissociation curve. And so basically all I want to show on the oxygen hemoglobin dissociation curve is, as that oxygen, your P50, so as your partial pressure of oxygen decreases, your hemoglobin in the body is going to have an increased affinity for oxygen. So therefore it's going to bind down, those hemoglobin molecules are going to bind that oxygen much more readily than it is accustomed to. And so therefore it actually makes it harder for it to unload into the peripheral tissues. But over time, the body will adjust to that and kind of shift itself back into neutral here over time. So high altitude illness prevention. Acute high altitude illness is a spectrum with slow ascent and acclimatization, the hallmarks of prevention. Typically, there's acute mountain sickness, there's high altitude cerebral edema, and high altitude pulmonary edema. The ascent rate that predisposes you to acute mountain illness is ascent rate greater than 3,000 meters or greater than 300 to 600 meters per day at levels above 3,000 meters. And then one way to help prevent this is taking a 24-hour period rest day for every 1,000 meters gained in order to help reduce and allow acclimatization at those current elevations. And as you can see here, the top right image shows an episode of what's called high altitude pulmonary edema. So you have your chest x-ray here, you have your lung fields that appear clear here, but you have this hazy infiltrate right here, which is evidence of pulmonary edema, and you can see it bilaterally. And then on the bottom right image, that's an example of high altitude cerebral edema. So you have the ventricles right here, and as you can see, there is swelling that is pushing on the fourth ventricle, which will then subsequently result in herniations, seizures, and death. So how do you prevent high altitude related illness? The most important things, besides acclimatization and getting them used to their environment, is hydration and nutrition. So hydration, as we discussed earlier, you're going to have an increased pulmonary minute ventilation rate. You're also going to have a diuresis that occurs. So you're going to be basically in a hypovolemic dehydrated state before you even initiate exercise or athletic activities from those increased insensible losses. So you got to make sure that they're having appropriate hydration during all times in pre-competition, intra-competition, and post-competition. The other thing is typically these high altitude, high exposure events, there's decreased free water availability because at that point in time, we're dealing with remote endurance training events. So you got to make sure that there's free water access for these individuals. The other thing is consider a high carbohydrate diet. So that helps improve your ventilatory rate and will also help improve your oxygenation and exercise performance while at altitude. So can we prevent high altitude sickness and acute mountain sickness? The answer is yes and no. And the reason being is most of our medications that we use for preventative purposes for acute mountain sickness are banned by the World Anti-Doping Association. So if you have somebody who's more of a recreational athlete who's not under these strict guidelines such as the NCAA, the WADA, you can consider a few medications. The most common one is acetazolamide or Diamox. It's typically dosed at 125 milligrams twice per day. You initiate it about 48 hours before the ascent, and you can continue it about 48 hours after your desired elevation. The benefit is it's a carbonic anhydrase inhibitor. And what that does is it promotes a metabolic acidosis. And so your kidneys subsequently excrete the bicarbonate. And so basically you're getting ahead of your adapted physiological state when you get to high altitude by promoting that metabolic acidosis in the body. Your body's going to compensate by increasing the ventilatory rate. So therefore, you basically are getting the respiratory alkalosis that you would normally get, except we're reducing it by medication. So you don't have to go through that physiological adaptation. Like I talked about earlier, it is banned under the World Anti-Doping Agency because it is a diuretic. So any competitive athlete would not be able to use this as part of prophylaxis. Dexamethasone or steroids are kind of the same thought process, same family. The typical dosing is 2 milligrams by mouth 4 times per day for acute mountain sickness, and then 4 to 8 milligrams by mouth 4 times per day for altitude pulmonary edema. The theory behind the physiologic benefits is it improves exercise capacity, but again, since this is a steroid containing material, it is banned by the World Anti-Doping Agency. So again, this would be reserved for your recreational athletes and non-competitive athletes. But there is some data that shows non-steroidal anti-inflammatory medications such as ibuprofen can help decrease the incidence and severity of symptoms with acute mountain sickness. Typical dosing is 600 milligrams by mouth 6 hours prior to ascent. Fortunately, like I mentioned, it is allowed as is not a banned substance. So if you're going to consider prophylaxis in your athletes for acute mountain sickness, ibuprofen is probably going to be the route to go. But keep in mind the gastritis, peptic ulcer disease, and renal insufficiency that can occur with chronic non-steroidal use. As with heat and cold, we got to be able to recognize, we got to be able to evaluate acute altitude sickness. We need to understand how we're going to descend and how we're going to treat pharmacologically, and then how we're going to get them to advanced care, because a lot of times in these altitude exposures, we're going to be in rural environments where it's kind of difficult to have EMS available at bedside at all times. So recognition, acute mountain sickness is typically seen with elevations greater than 2,000 meters or a rapid ascent greater than 300 meters per day. It typically presents in the first 24 to 48 hours after ascent. And the signs and symptoms are typical kind of prodrome, not feeling too well stuff. So you get your headache, you get nausea, you get anorexia, you get your fatigue, you get your insomnia. But the big identifying factor that separates it from high altitude cerebral edema and high altitude pulmonary edema is there's no focal neurological or pulmonary symptoms. So there shouldn't be exertional shortness of breath. There shouldn't be associated chest pain. There shouldn't be ataxia. There shouldn't be nystagmus or anything that's abnormal from the physical examination. This table below here is the Lake Louise Acute Mountain Sickness Score. It kind of uses different symptoms such as headache, GI symptoms, fatigue, dizziness, and altered mental status to help classify someone if they're in mild, moderate, severe acute mountain sickness. Now, I would use this more as a guideline. That is not a true patient-recorded outcome measure. It is more a research study measure, but I think it gives you a good baseline when evaluating your athletes to kind of figure out how symptomatic are they with their acute mountain sickness issues. As opposed to severe mountain sickness, so this is high altitude cerebral edema, high altitude pulmonary edema. For high altitude pulmonary edema, you get the symptoms of acute mountain sickness plus your cardiopulmonary symptoms. So your dyspnea at rest, your cyanosis, your hypoxemia, your peripheral edema, which will subsequently result in non-cardiogenic pulmonary edema from overload and capillary permeability. And then high altitude cerebral edema, you get your symptoms of acute mountain sickness plus focal neurological findings such as ataxia and altered mental status at that point in time. So what is the management for both of these conditions, or all three of these conditions? For acute mountain sickness, it's symptomatic management. You know, we were considering earlier about your prophylaxis medications, your dexamethasone, your acetazolamide, and your nonsteroidal anti-inflammatory medications. Once you have onset of these symptoms, typically the prophylaxis medications efficacy kind of goes down, and you kind of just have to treat them supportively through that time. Ascent should be discontinued until symptoms have completely resolved, and that can take a period of 24 to 48 hours, depending on the athlete and the individual themselves. It's also important to promote hydration, sleep hygiene, diet, and activity. Modification should be encouraged as well during that point in time. And then descent should only be reserved for refractory symptoms. And there's no real established guidelines for the rate of descent, but typically you start descending until symptoms start feeling better. Once symptoms start feeling better, then you can say, hey, that's our baseline descent location at that point in time, and just leave them there till symptoms resolve. For severe mountain sickness, so your HAPE and your HACE, this constitutes a medical emergency at that point in time. There's no pass go, there's no collect $200. The first treatment and the first thing you should do is begin immediate descent. There is not an established rate of descent, but at that point in time, I would try to get them as low as safely possible in the quickest fashion, where I can get them access to EMS services. Because typically, if there's evidence of pulmonary edema or cerebral edema, advanced care is warranted in order to prevent subsequent cardiac arrest and pulmonary from the HAPE method or herniation from HACE. So other measures can be done, so supportive care measures, particularly for high altitude pulmonary edema, since it's a cardiopulmonary process. You can do high flow oxygen with positive pressure to help try to push that pulmonary edema back into the vascular regions instead of the lungs. And then you can also consider portable hyperbaric oxygen container if available for same exact reason. By increasing the oxygen content, the pressure of the oxygen content, you can help push the pulmonary edema back into the vascular territories. From a pharmacological standpoint, you can consider dexamethasone, 48 milligrams as needed. And then for high altitude pulmonary edema, you can also consider the calcium channel blocker, nifedipine, but these will be advanced care treatments once they have been descended and been removed from the environment. So this image just shows a few things that you can do at that point in time. So probably what you're going to have available at your kit if you're dealing with altitude medicine is probably the oxygen tank and the reservoir bag, as you see here, that can promote high flow oxygen. The top left image shows a portable hyperbaric oxygen container. You can kind of you put the athlete in it, seal it in, and it could be used as a portable transport, and it can also be used as a treatment modality, depending if descent's not available. And then there are ampule injections such as dexamethasone that come pre-dosed into 4 to 8 milligrams that can be taken out and delivered as needed in the event that descent or appropriate treatment is not available in the environment. So as were other ones, there's my algorithm for altitude illness. It's pretty straightforward as well. First question when you're dealing with acute mountain sickness or high altitude pulmonary edema or cerebral edema, is there evidence of any altered mental status, ataxia, or cardiopulmonary symptoms? If there's not, then you're dealing with likely acute mountain sickness. You know, you go through your supportive care measures, your nutrition, your hydration, stop your ascent, use prophylactic pharmacology as needed. If there's improvement, you continue supportive care and you monitor for reoccurrence. If they're not improving, then you consider supportive care, and then you consider cessation of all activities till they improve, or even consider descent. As opposed to the other side, if there is evidence of severe mountain sickness, such as high altitude cerebral edema or pulmonary edema, you should activate your EAP and EMS. And the big question at that point in time is rapid descent delayed. If rapid descent is not delayed, then immediately start having the athlete packaged and removed from the environment, be it descending as fast and as safely as possible. You can also promote high oxygen therapy at that point in time, as well as your prophylaxis and treatment pharmacology. And then these patients need to be transferred to advanced tertiary care facility, as they typically need advanced diagnostic imaging, as well as continued pharmacology medications to help prevent cerebral herniation or cardiac arrest in the setting of pulmonary edema. Now, if rapid descent is delayed, this is when you consider your supportive care. So high flow oxygen at that point in time, your hyperbaric oxygen, if available, advanced EMS care. So this is when you get life flight involved, if possible, high flow oxygen. And if there's a significant delay and there's worsening mental status, worsening neurological findings, then even you consider advanced airway access. So do you consider intubation? By intubating and putting a positive pressure environment, you're definitely going to treat the pulmonary edema at that point in time. Go ahead and attain IV access. You also need to be prepared for any ACLS, BLS, AED. You need to have all your things ready and available at that point in time if there's a significant delay for descent, as these patients can deteriorate pretty quickly. So finally, we're going to talk about altitude training in the athlete. I do have this question that occurs every so often. And so who's indicated for altitude training? These are typically going to be your endurance athletes in which VO2 max is important. So this is going to be rowers. This is going to be marathon events. This is going to be biathlons, all those type things where you need that aerobic oxygen carrying capacity. And then other considerations would be those who compete at altitude. So that would be those athletes who are in Denver, Mexico City, or other cities that have higher elevation greater than 2,000 meters. Elite, well-trained athletes with general and competitive specific fitness typically get the benefits of altitude training better than not well-conditioned athletes. So more of your competitive, elite, Olympic athletes will have much better improvements and see much better benefits from altitude training as opposed to your high school or collegiate athletes. Altitude training is not a substitute for traditional training programs with appropriate rest and nutrition. So who's not indicated for altitude training? So this is your team sports type stuff, where they really don't have that need for that VO2 max and that long aerobic endurance activity. Sports that depend on normal air resistance are also not a good area for altitude training. You don't really want your baseball players, your punters, your kickers, your archery, tennis individuals practicing at altitude if they're going to be training at sea level, whenever the decreased air resistance is going to change how the projectiles occur during activity. Iron deficient athletes are also not a good candidate for altitude training. The reason for that is one of the physiological responses, as we discussed earlier, is to increase the total red blood cell mass with prolonged altitude training. So if you have an iron deficient athlete, they are not going to have that red blood cell mass response, as they do not have the iron needed in order to create more hemoglobin. And so therefore they would not get the benefit from altitude training. So altitude training the athlete, competitions at altitude, acclimatization is critical and improves performance at altitude. Performance incrementally improves at altitude of approximately 14 to 19 days. If acclimatization is not achievable, competition within 2 to 4 hours of arrival is recommended. So basically what it's saying is, in order to have your maximum best time to compete, if you're not accustomed to high altitudes, is either get yourself there and give yourself time to acclimate over 14 to 19 days, or have them come in and start competing as soon as they arrive there, as they noted that the onset of acute mountain sickness and altitude related issues kind of occur in the first 5 to 6 hours with onset. And then of course your first 48 hours the most symptomatic, but they don't get that physiological adaptation until about 2 weeks into being there. So competitions at sea level. So there's 3 methods that have been studied and been trained, and only one has been shown to show improvement with exercise and performance. The first one is living and training at high altitude. So live high, train high has not been shown to improve performance at sea level. Non-significant improvement of mean aerobic power was shown, but nothing that really changed their performance between the athletes. The next method is live low, train high. So that's when you live at sea level and you train at a high altitude. That has not been shown to improve performance either. The only one that has been shown to prove performance in athletes is living high and training low. And so that study demonstrated a 4% improvement in mean aerobic power, which doesn't seem like a lot, but if you're an elite or Olympic level athlete, 4% improvement is a pretty significant marker, particularly when everybody around you's times are measured within milliseconds with these competitions. So if you're going to live high and train low, how high should you live? Locations around 2,200 to 2,700 meters above sea level will maximize acclimatization. So around here in Texas, around Lubbock and El Paso. How long should your hypoxic exposure be? Should be around 14 hours to allow that physiological adaptation to occur. So then the next question is, how long do you stay at altitude in order to get those maximum benefits? You want a minimum of 3 to 4 weeks of acclimatization. At this point in time, that promotes erythropoietin production. Erythropoietin is the hormone that allows red blood cell production and activation. And so at that 3 to 4 weeks, that's when you're going to get that increased red blood cell mass, which will subsequently improve that oxygen carrying capacity and VO2 max. How high should you train? High intensity training, so high intensity, is best to complete the workout at low altitudes. So when you're doing these altitude training, you're not training at 3,000, 4,000, 5,000 meters. You're training within the 2,000 to 3,000 meter range, but your ultimate high intensity training should occur at less than 1,500 meters, while low intensity training can be performed at the altitude that you're currently at. Then the next question is, when do I return to sea level to go for competition? Your competition should be completed upon return within 72 hours to maximize the red cell mass. After about 72 hours, the body starts adapting and starts going back to its typical physiological state, and you'll start having decrease in the total red blood cell mass that you attained while at altitude. There are a few athletes that mentioned between that 3 to 14 day mark, they kind of feel the flatness or the fatigue with returning back to sea level. So it's recommended kind of avoid those days if you're returning back to sea level, and then picking up your competition back at 2 to 3 weeks. So if you're going to return back from altitude training to get your maximum benefit, you either do it the first 72 hours upon arrival, or you need to wait 2 to 3 weeks in order to get those maximum exercise benefits. And then finally, iron supplementation. Iron store is particularly important for altitude training. Iron deficiency blunts the red blood cell production. Despite the elevated erythropoietin, you need the products in order to make the product. And then iron deficiency results in minimum VO2 changes. For athletes considering altitude training, hemoglobin and iron levels should be obtained. And for women, the typical number is 20 nanograms per milliliter, and men is 30 nanograms per milliliter. And then iron supplementation should be administered in both normal and iron deficient athletes who are training at altitude. And that's about 150 to 400 milligrams of elemental iron daily. That's my bibliography. And thank you for your time today. If you have any questions, please reach out to me at this email address, and I will try to get back to you in any way possible. You'll have a great day.